So in last class, we talked about the hormones which are secreted from even hypothalamus, also like GnRH, okay, gonadotropin releasing hormone. Then we talked about the growth hormone, its agonist, okay, and antagonist. So this was the last slide which we discussed in the last class, isn't it? So Peggy so meant it is a growth hormone receptor antagonist which could be used in acromegaly, which is due to small pituitary adenomas. If there is a large, then we go with the surgery. That is what is preferred one. And if it is small or surgery is done, and then it could be used. Okay. So now after this, let us discuss about prolactin. Prolactin is again a hormone which is released from anterior pituitary gland and directly act on the organs. Okay, so this is one hormone which directly act on the organ, not on the gland. Okay, so basically the other anterior pituitary hormone they use to act on a gland, and from a gland hormone is released, and that hormone produces the action. Okay, but in case of prolactin, this directly act on a organ and produces the response. Okay, so it is said mammotropin, or it is a lactogenic hormone, okay, which is the main hormone for lactation, okay, that causes lactation. So this prolactin, it is a peptide hormone. The nature of this hormone is peptide, and it is secreted by anterior pituitary lobe, and it is structurally similar to GH, okay, growth hormone. Structurally, it is similar, okay. So, and this prolactin, what does it do after releasing from anterior pituitary uh, gland? It causes growth and development. It helps in growth and development of a breast, especially during the pregnancy. In pregnancy, these are released in more, and then that causes growth and development. And it is a principal hormone. It is a main hormone for lactation. Okay, it is not only hormone, but it is a main hormone. Why I am emphasizing on the main hormone? Because it is required. In absence, there will be no lactation, but in presence also, it requires something else. Okay, like when there is appropriate level of estrogen, progestin, corticosteroid, insulin present, and at that time, if this prolactin is also there, then it stimulates the milk production. Okay, so that is why it is the main hormone to produce the milk, help or stimulate in production of milk. But along with this, the other hormones should also be there. Okay, which is generally during pregnancy, okay, or after birth. These are hormones come into the picture, and then there is a milk formation and ejection. Now prolactin, how it is regulated. Okay, so regulation of prolactin, it is done by hypothalamus. Okay, hypothalamus when okay, it releases prolactin releasing hormone which stimulate anterior pituitary hormone to release prolactin. Okay, similarly the hypothalamus inhibit the prolactin, okay, release by releasing the prolactin release inhibitory hormone PRIH or dopamine. Okay, so this dopamine inhibit the release of prolactin, while prolactin releasing hormone facilitate the release of prolactin from anterior pituitary gland. Okay, so anterior pituitary gland, when it is stimulated with PRH, okay, it releases prolactin, and this prolactin will directly act on the organ and produces like breast development and milk production. Okay, so prolactin does that. Now, when there is milk development, when the baby suck, okay, for the milk, when there is suckling reflex, that will give a positive feedback, okay, positive feedback to hypothalamus to release more prolactin releasing hormone, and that will cause more release of prolactin, and that will again cause more production of milk. So this is a positive feedback. Similarly, this prolactin also give the positive feedback directly also. Okay, the suckling reflex also give the positive feedback, as well as prolactin itself give a positive feedback, and then PRH is released more, and the anterior pituitary hormone is stimulated to release prolactin. Okay, so this is how the regulation of prolactin is done. And now disorder of prolactin, generally there is the deficiency of prolactin is very, very rare. Okay, so prolactin as such, we don't have a formulation or the preparation for prolactin because they are rarely being used. But however, the hyperprolactinemia, that means more level of prolactin in blood, is very common. Okay, and when it happens, when there is hyperprolactinemia, in female, it causes the syndrome of galactorrhea and amenorrhea, okay, which causes infertility. What happens? The prolactin inhibit the GnRH, gonadotropin releasing hormone. So that is why what happens is it causes infertility, amenorrhea. It is very, very important, and this is one of the reason, like a lactating mother, okay, are like natural, this is a natural contraception. Okay, the pregnancy will not happen lactating mother, because the prolactin level is higher in those cases, which inhibit the gonadotropin releasing hormone. Okay, so our sexual hormones activity will be decreased, and that lead to infertility. So that is why after delivery for 6 months there is natural contraceptions. Okay, the reason is that. Okay, so similarly, if the prolactin level is high in male, it loses the libido and causes infertility. Okay, so this is hyperprolactinemia cause. So basically it causes galactorrhea in female, and amenorrhea, infertility in both male and female. What is the cause for this? Why there is excessive prolactin in the blood? Okay, it could be like prolactin secreting pituitary adenomas, which could be a smaller or bigger, micro or macro adenomas. So the prolactin secreting cells, okay, could drastically grow, and that may lead to adenomas. Okay, so that could be the cause for hyperprolactinemia. Similarly, the drug could also cause prolactinemia. Okay, drug, especially now, if you see the regulation, now this dopamine decreases prolactin. Okay, so what happened to dopamine if we use dopamine antagonist? Then what will happen? This inhibitory action, the inhibition will become weaker. Okay, and prolactin will be excess. Okay, dopamine antagonist, especially dopamine antagonist which act on a brain, okay, which cross the blood-brain barrier. The dopamine antagonist, the blocker of dopamine which cross the brain, may cause prolactinemia. Okay, got it? Am I audible to you all?
Yes, sir. Yes, sir.
Roll number, roll number 20. Roll number 20. Roll number 19. So 19 and 20 are absent. Roll number 55. Roll number 55. 56. Roll number 56. 57.
Yes, sir.
So this is roll number 57.
No, sir.
Yes,
56.
sir.
Yes? 57.
Yes, sir.
Okay. So which drug causes hyperprolactinemia? Which medicine? "57, are you there?
Yes, sir. Sir, dopamine.
Dopamine causes hyperprolactinemia.
Sir,
Dopamine will
dopamine antagonist.
antagonist. Can you name one dopamine antagonist which you have read in third semester? One dopamine antagonist. No?
Sir,
Yes?
phenothiazine.
Phenothiazine. Which group does it belong to? Where do you read that in third semester? Hmm? 58. Roll number 58. 59. 60.
Yes,
Absent.
sir. Yes, sir.
Okay. Which can you name one dopamine antagonist which you have read in third semester?
Promethazine.
Sorry?
Um,
Sorry?
I don't know.
Roll number 9. Yes.
Yes,
Are you
sir.
there?
Yes, sir.
Yes. Any antagonist which you have read in third semester which act on brain, okay, and causes hyperprolactinemia. In anti-emetic, have you read some drug? Anti-emetic.
Yes, sir.
Yes. Dopamine antagonist. Can you name some dopamine antagonist? Anti-emetic.
Sir, metoclopramide.
Okay, very good. So metoclopramide, it crosses the blood-brain barrier and then inhibit the this like dopamine. So that is why there will be excess prolactin, and that is why there is prolactinemia. So if you go back to metoclopramide and see, then you will get the side effect. That side effect explained over there. Okay. So dopamine antagonist and the drug which decreases the dopamine level in brain especially, okay, they may cause hyperprolactinemia. Okay, so how we treat this hyperprolactinemia? If there is adenomas, especially a bigger one, we go with surgery or irradiation therapy, that is radiation. And dopamine agonist. Now, see, dopamine antagonist increases the prolactin level. Dopamine agonist will decrease the prolactin level. So generally dopamine agonist could be used, and this is generally preferred when there is the size of adenoma is smaller, okay, and it decreases the secretion and the size of adenoma. So if there is pituitary adenoma in a smaller size, then you can use medicines which are dopamine agonists, the bromocriptine, cabergoline, okay. So similarly, those. But if it is bigger, then we go with surgery. Okay. If hyperprolactinemia is due to medicine, like I have already said, the medicine, the dopamine antagonist causes hyperprolactinemia. And now see, there are in brain, there are various dopamine pathways. Okay, at least 4 pathway we will be discussing in CNS. At that time, you have to correlate those with this. Okay, so in CNS, like if someone is suffering from schizophrenia or say the psychic disorder, okay, antipsychotic drugs, they are dopamine antagonists, they act on brain. So those drugs will increase the prolactin level in the blood, okay, hyperprolactinemia. So that is why if it is due to that, then the drug, if hyperprolactinemia is due to medicine, then if possible we have to stop that medicine to treat that hyperprolactinemia. If you want to treat hyperprolactinemia, then think of withdrawing that drug if possible. Okay, you have to see the benefit and the risk of withdrawing that medicine. Okay, and there is no clinical use of prolactin as such. Prolactin as such we don't use therapeutically. Okay, now let us talk about bromocriptine. Bromocriptine is dopamine agonist, so it decreases the prolactin level in the blood. So it is synthetic ergot derivative, a potent dopamine agonist. And generally this dopamine act on various receptors, okay, D1, D2. So D2, which is present in pituitary gland, okay, it has the bromocriptine has greater agonistic action, okay, so it mimic the action in pituitary gland. So that is why bromocriptine is commonly used for therapeutic purpose. And this bromocriptine has partial agonist or antagonist action on D1 receptor, okay. So it has partial agonistic antagonist action, as well as it has agonistic action on D2 receptor, which is there in pituitary gland. Okay, so it decreases pituitary prolactin secretion. Okay, and growth hormone, it affects the, because the structure we have said that the prolactin structure and growth hormone is similar. So this growth hormone is also affected, and this effect is different. Okay, in normal individual, there will be increased growth hormone, the release of growth hormone will be more, while if someone is having a pituitary tumor, then it will cause decrease in growth hormone. Okay, so the bromocriptine will affect the GS secretion, and it is useful in Parkinsonism patient, because in Parkinsonism the dopamine level in the brain decreases, especially nigrostriatal pathway. So these are the dopamine agonists, so they will act as that of dopamine in that pathway, and improve the symptoms of Parkinsonism. So they are useful. Okay, so bromocriptine is also used in Parkinsonism. And dopamine causes nausea and vomiting, by acting on CTZ, chemoreceptor trigger zone. So please correlate. In third, in anti-emetic, we have causes vomiting by acting on CTZ. It the dopamine will decrease the motility. That is why the dopamine blocker was used as an anti-emetic and as a to increase the peristaltic movement, isn't it? Okay, so if you could remember the metoclopramide, domperidone. Now see, domperidone and metoclopramide, it is different. Like domperidone doesn't cross blood-brain barrier. So increasing the prolactin level is not there with the domperidone. So please try to correlate this with antiemetic. Okay, so this bromocriptine, dopamine agonist, they decrease GI motility. So that is why the dopamine blocker are prokinetic. You have read in the antiemetic section. Okay, so this is the most important side effect, nausea, vomiting, and the rationale behind this nausea, vomiting is that it acts on dopamine receptor present in CTZ, chemoreceptor trigger zone. It also causes hypotension, and this hypotensive action is central as well as peripheral. Okay, and it decreases GI motility, bromocriptine. Now, talking about the pharmacokinetics, it has less oral bioavailability. Why? Because it has very less oral absorption. That is only 1/3 of the drug which we take is absorbed. Okay, and it also undergo high first pass metabolism. Due to less absorption and high first pass metabolism, the bioavailability, oral bioavailability is very low. Okay, and metabolite are excreted mainly in bile. T half is just 3 to 6 hours, and generally bromocriptine we start with the low dose. Okay, that is 1.25 milligram, and slowly we increase the dose because of the two important, the hypotension, one side effect, then the other one is nausea, vomiting. So that is why if you start in higher dose, those side effect will decrease the patient compliance. The patient will not like to take the drug. So that is why we start in low dose and then gradually increase. Okay, bromocriptine. Now, where we use bromocriptine is in hyperprolactinemia. Okay, when prolactin level is higher, in acromegaly. Okay, because in the tumor it decreases the growth hormone secretion. Okay, and in Parkinsonism also it is used, but in Parkinsonism we use in very high dose, like 20 to 80 milligram per day. Okay, so bromocriptine. The side effects of bromocriptine is nausea, vomiting, as we have already said, and it decreases peristaltic movement, so that is why there will be constipation. Okay, it is, these all action are opposite to that of metoclopramide or the domperidone. Okay, so it also causes nasal blockade and postural hypotension. Okay, and this postural hypotension is more when the patient is taking antihypertensive medicine. Also antihypertensive also try to decrease the blood pressure, and this bromocriptine also decrease the blood pressure, so there will be more prominent or more fall in blood pressure. Okay, and this is early immediately seen side effects, are these are the immediately seen side effect. And remember, there will be late side effect also. Okay, because there will be behavioral alteration. Now here just you remember that if dopamine level in our brain is especially mesolimbic mesocortical pathway, if dopamine increases, then the psychotic behavior will happen. So that is why in a psychosis we use dopamine antagonist. Okay, So when we use bromocriptine, the dopamine activity in this mesolimbic mesocortical pathway will increase, and that will alter the behavior. Okay, there will be mental confusion, hallucination, psychosis, abnormal movement. Why abnormal movement? Because in nigrostriatal pathway also there is dopamine. So this is, but for this you have to use bromocriptine for long period of time. Okay, on chronic use only we see these side effects. Okay, so this side effect, please try to correlate. Now this the bromocriptine, the increase in prolactin level will if you associated this with the dopamine pathway in a brain in CNS, then it will be very easier. If you understand here, then you can correlate it in CNS, and CNS will become easier. When you understand in CNS, bring it, then here it will be easier. Okay, so dopamine, there are various pathway in our brain. Okay, and we will be talking those pathway, what will happen when dopamine level increases or decreases. As per that, you can correlate these also. Okay, got it?
Yes, sir.
Okay. So this is bromocriptine, cabergoline. So this is again a newer D2 agonist. Okay, like bromocriptine, it was acting on both D1 and D2, not very specifically to D2, but this act on D2. Okay, and that is why it is more potent, more selective because it is acting on D2, while bromocriptine was acting on D1 and D2. So selectivity is more, and it is longer acting. Even twice a week is sufficient. So that is why bromocriptine are nowadays not very common, or this is more preferred over the bromocriptine. But the cost, you have to see the cost also. So cost of this is a little bit higher, and it is not easily available, while bromocriptine, they are little cheaper and easily available. Okay, so this is the scenario. So but cabergoline we prefer over bromocriptine. So the next one more dopamine agonist, which is non-ergot dopamine. It is not derived from ergot. Okay, and this has less adverse effect. So this is the other option, quinagolide. Okay, and so this is all about the prolactin and its antagonist. Now let us talk about the gonadotropins. We have already discussed gonadotropin releasing hormone in the previous class as a hormone from the hypothalamus. Okay. Now, when they are released from hypothalamus, they act on anterior pituitary gland, and then anterior pituitary gland will release the gonadotropins, which is the FSH and LH. Okay, so gonadotropin are follicular stimulating hormone and luteinizing hormone. The function of this is, in women, this follicular FSH, follicle stimulating hormone, causes follicular growth, development of ovum, and secretion of estrogen, while in male it causes spermatogenesis. Similarly, the LH, luteinizing hormone, in women causes it promotes the ovulation, formation of corpus luteum till the next menstrual cycle, secretion of progesterone, and in male it causes testosterone secretion. So in detail, the FSH, LH, it will be taught in detail in physiology. Okay, so here just revision sort of thing is there, or the portion which is important from pharmacology point of view. Okay, so if there is disturbance in gonadotropin secretion, okay, so if the secretion is lesser, it may delay the puberty, and if secretion is higher, Okay, disturbance means either there will be low secretion or higher secretion. Low secretion delay the puberty, while if there is higher secretion, the puberty will appear earlier in both girls and boys. Okay, so inadequate GN secretion result in women what happens, there will be amenorrhea and sterility. Okay, while in male there is importance infertility. So when this gonadotropin is lesser, there will be infertility. So excess production of gonadotropin in adult women causes polycystic ovaries syndrome. Now, preparation for gonadotropins. Okay, gonadotropins, these are not only released by the anterior pituitary gland, but from other places also. So that is why we have a lot of preparations. Okay, we have like minotropin. Minotropins is a combination of FSH and LH. It is obtained from urine of menopausal woman. Okay, and we have urofolitropin or minotropin, which is a pure FSH. Okay, it is not a mixture of FSH and LH. There is no luteinizing hormone, only pure FSH. It is preferred over combination. Okay, it is preferred over menotropin for induction of ovulation in women with polycystic ovarian diseases, and even the pregnant lady, okay, especially from fetal placenta, it secretes human chorionic gonadotropin, okay, human HCG, okay, which is absorbed. The fetal placenta prepare that, and then mother will take that, absorb it, and maintain the corpus luteum during the pregnancy. So that is why okay, it is present in pregnant women. So that is why it is derived from the urine of pregnant women. And this is sometimes very commonly used nowadays, especially in obs-gynae department, especially where there is the chances of threatened abortion or pregnancy. The maintenance of pregnancy is difficult at that time. It might be due to the deficiency of this hormone. So this preparation is preferred. Okay. So similarly, the other preparation we have recombinant human FSH. Okay, with recombinant DNA technology. Now the FSH has also been prepared. So that is what we say folitropin alpha and beta. Folitropin alpha, folitropin beta are available, and recombinant this chorionic gonadotropin, which we say choriogonadotropin alpha. Okay, this is also available, and even the recombinant human luteinizing hormone was available, but now it has been withdrawn from the market. So anyway, the preparation is there, but because of its adverse effect and other thing, it has been withdrawn from the market. Okay. So these are some of the preparation of gonadotropins. Okay. So where we use these gonadotropin, we use in amenorrhea and infertility due to deficiency of gonadotropin. When there is deficiency, amenorrhea, infertility due to prolactin, we don't use this. Okay. When there is deficiency of gonadotropin, then we use it. And to aid in vitro fertilization, or what we say test tube baby, okay, to get a very quality ovum, sometimes it is used. A hypogonadotropic hypogonadism in male. Okay, so there is a deficiency of these gonadotropic hormone as well as gonadotropes. In that case, it is in male it could be used, which is the symptoms of this is or it is manifested as delayed puberty or defective spermatogenesis. Oligozoospermia is male sterility, etc. Okay, and adverse effect when we use this in higher dose. Okay, you can predict what will be the side effect. There will be ovarian will be stimulated more, so ovarian hyperstimulation syndrome could happen. Okay, the symptom or manifestation is polycystic ovary, pain in lower abdomen, ovarian bleeding, etc. There could be multiple pregnancy. The puberty may happen early, so precocious puberty happen. There could be allergic reactions and edema, headache, mood change. These are the side effects of gonadotropes. Okay. So this finishes the hormones of anterior pituitary gland. Okay. If you have any doubt, you can ask. Otherwise, there are few MCQs which we have to discuss before completing this lecture. Anyone who have questions? Yes. I hope there is no questions. Now let us see some MCQs. Hormone R, the option is product of endocrine gland secretion, mediator of inflammatory process, byproduct of tissue metabolism, product of exocrine gland secretion. Which one is correct answer? Roll number 1.
Yes, sir.
Which one is correct answer?
First, sir, products of endocrine gland secretion.
So A, isn't it?
A.
Okay, good. So this is a product of endocrine gland. It is not a product of exocrine gland. It is endocrine. So option A is correct. Similarly, in the next MCQ, which of the following is not an adverse effect of growth hormone? Okay, therapy. When we give growth hormone, what are the which is not an adverse effect? Okay, that means we have to tick the adverse. We have to exclude. Okay, like we have to see what are the adverse effect, and then we can exclude. The excluded will be the answer. That means which is not. Okay, emphasize on this, not which is not the adverse effect of growth hormone therapy. What do you think? Which one is the correct option? Roll number 2. Roll number 2.
Sir, carpal tunnel syndrome.
Okay. No. It. Okay. No. Roll number 3.
Yes, sir.
Yes. Which one is the
Sir, C.
sorry?
C, sir.
No. 4. 4. Roll number 4.
Hypoglycemia.
Who is that?
Hypoglycemia.
Who has given that answer? Your name?
Sir, Shreya Agrawal.
Okay, Shreya, you are 100% correct. In yesterday's class, I have emphasized a lot on growth hormone action, and what I said was growth hormone increase blood sugar level, isn't it? It increases. So when you give growth hormone, there will be a chance of hyperglycemia. So it never causes hypoglycemia, isn't it? Last in yesterday's class, I said growth hormone increases blood glucose level. If the that increased blood glucose will stimulate the insulin release. If the patient is normal, could able to release the insulin, then it will the insulin will bring back that blood glucose level will come to the normal. If no, the patient is diabetic, then there will be hyperglycemia. There will be drastical, okay, unpredictable hyperglycemia. So hyperglycemia is the adverse effect, okay, but not hypoglycemia. So that is why B is the correct option, okay. Somatostatin can be used in all cases except somatostatin also yesterday we discussed, isn't it? What is the correct option? Anyone?
D.
Gallstone.
Gallstones.
Gallstone. Okay. Yes, option D is a correct answer because gallstone is not the use, rather it is a side effect of somatostatin. Okay. Acromegaly, in bleeding peptic ulcer, in bleeding esophageal varices, it could be used, but gallstone is the side effect of somatostatin, isn't it? So that is why it is not used in gallstone. So D is the correct option. Next, indication of bromocriptine are following. Which one?
A.
Yes. C. Bromocriptine is what? Dopamine agonist, isn't it? Dopamine causes prolactin, increase prolactin secretion or decrease?
A is the one.
Hmm? Yes. Prolactin secreting adenomas, it could be used or not? It could be used. It could be used in amenorrhea, galactorrhea, and then acromegaly. So C is the correct answer, isn't it?
Yes.
Yes, sir.
Now last one SAQ. A 22-year-old female, Nita, presented to you with complaint of headache and vomiting since 2 months. She is having amenorrhea, but urine pregnancy test is negative. Okay, no menstrual cycle, but since last 2 months, but the pregnancy test is negative. Okay, so she also complained of secretion of milk from the breast. So secretion, there is amenorrhea and galactorrhea. So what could be the diagnosis over here? And MRI confirmed the presence of large pituitary adenoma. There is a adenoma, but which adenoma could be this?
Prolactin secreting.
Okay. And Nita was advised for surgery. However, she is not willing to undergo surgery. Which medicine will you prescribe and why? Okay, anyone?
Bromocriptine.
Who is that?
Shreya. Shreya Agrawal.
Yes. Then why you are speaking very slowly? When you are correct, speak loudly. You are correct. Yes, why? Can you give the reason?
So because it is a dopamine agonist, and so we give that because it blocks
Okay.
GnRH.
Okay, I hope you have understood this is dopamine agonist, which we prefer. Okay. Hello, are you listening to me?
Yes, sir.
Okay.
Yes, sir.
So this is dopamine agonist, which is used in that case. So this completes our the hormones from anterior pituitary gland. If you have any